Thank you, Kevin. This is a real privilege for me to be back here at the 4th Annual Duke Valve Symposium. I've been a part of every one of these, and it's just a tremendous opportunity. I'm really thankful to Kevin and Chad and the planning committee for having me back. As a proud alum of this cardiology fellowship program and a graduate of the structural heart disease program, it's just a real treat for me to be back amongst so many friends and colleagues. What I hope to talk to you about over the next 20 or 30 minutes or so is something that's really become a hot topic within the world of TAVR and has really generated a lot of buzz. And it's mostly because at this point we still have more questions than answers, and we're not exactly sure what all this means and clinically what this means for our patients. And this is the topic of bioprosthetic valve thrombosis, or leaflet immobility, that we really think it may be due to valve thrombosis. And so what I hope to share with you here in the next little bit is what we know about this from some clinical trials and from some registries, but really share with you mostly what we don't yet know about this and don't really know yet how to handle this. A lot of this started and was sparked from this publication that's been alluded to a couple of times that was published back in the New England Journal back in the fall. This was a study led by Raj Makkar and others where they reported for the first time this phenomenon of leaflet immobility, both in TAVR valves and in surgical valves, seen by cardiac CT. It was sparked by a finding from the Portico IDE trial. As you've heard, the Portico trial is studying St. Jude's TAVR valve, the Portico valve. In this trial, and for the first time really, patients who received TAVR were then required to undergo 4-dimensional volume-rendered CT scans 30 days after valve implantation. And this was largely designed to assess stent frame structure. But what they found was a surprising finding in that they found that some of the leaflets of the TAVR valves were immobile or stuck after TAVR implantation. And so this was sparked by one particular patient where they saw a reduced leaflet motion in a patient who had a stroke after TAVR, and then a second patient who had the same finding but was asymptomatic. And so this led to a pause in the St. Jude Portico trial where they determined that it was time to take a break, let's take a closer look and try and figure out what's going on. And so there was a systematic review of CT data from 3 cohorts. One was from this Portico clinical trial, one was from this Resolve registry, which was a physician-initiated retrospective registry conducted at Cedars-Sinai Hospital, and then the Savory registry, which was a single-center prospective registry done at a hospital in Copenhagen. And I want to spend a few minutes sort of drilling down into the data from this trial and from the registries because it sort of helps us understand the issue at hand. So in the Portico trial, there were 55 patients who received a CT scan at a median time of 32 days after their TAVR implant. Of the 55 patients, 22 of them, or 40% of them, had reduced leaflet mobility, so quite a high number. Of the 37 patients who had received a Portico valve, 43% of them had reduced leaflet function. Of the 14 patients who received Sapien XT, 43% had reduced leaflet mobility. Of the 4 who received core valves, none of them had reduced leaflet mobility, but again, it was only 4 core valves. If you look at just the 22 valves that had reduced leaflet mobility, 15 of them had 1 leaflet affected, 6 had 2 leaflets affected, and 1 of them actually had all 3 leaflets affected. The Resolve and Savory registries were helpful because they included surgical valves in addition to TAVR valves. And what you find is that this is a phenomenon not unique to TAVR valves and also is true in surgical bioprosthetic valves, although the rates seem to be a little bit less. So there are 132 patients in this combined registry, 70 from the Resolve registry, 62 from Savory. They had CT scans a median time of 87 days after valve implant. It was mostly TAVR patients, 105 to 27 surgical valves, and of the total cohort, 13% had some reduced leaflet mobility. It was found in 14% of the TAVR valves and just 7% of the surgical valves, so a much lower rate in the surgical valves, but the surgical valves weren't free of this problem. In the Portico trial, all patients with reduced leaflet motion had hypoattenuating opacities on CT that corresponded to the base of the valve leaflets, that these hypoattenuations were seen in the areas where there was leaflet immobility. But what was most concerning, I think, in my mind, was that standard transthoracic echo, which is what we largely use to follow our patients after valve implantation, really did not demonstrate an increased gradient. And so what we typically do now as routine of care is standard chest wall echoes really was not very good in picking this up. But fortunately, in the Portico trial, of the 22 patients who had had this reduced leaflet motion on CT, 10 of them had a transesophageal echo. And transesophageal echo actually does seem to correlate with what was seen on the CT scan. So there was actually 100% concordance between the assessment of leaflet motion on transesophageal echo with TEE, and there was a hyperechogenic homogeneous mass on the aortic surface of those leaflets that weren't moving. But again, not necessarily a significant elevation in gradient. So you could have one of the three leaflets, or sometimes even two of the three leaflets, not moving very well, have this hypoechogenic mass, which was suggestive of thrombus, and really not see much change in gradient. And so for those reasons, chest wall echo really isn't that great at screening for this. This is a picture that Todd showed earlier today, but I'll spend some time explaining to you what it shows. So looking across the top row, this is grayscale 2D imaging of CT scan, showing these hypoattenuating opacities near the leaflets of these valves. The middle row is these 4D volume rendered CT pictures, which are just spectacular pictures. The middle row is in diastole, the bottom row is in systole. And so what you see here is that these hypoattenuated lesions on grayscale, which are very consistent with thrombus, correlate very well with the leaflets that don't open. So it's mounting evidence that this is thrombus that's causing this. And further things that support this, that this is thrombus, is the impact of warfarin on this. So if you look at in the Portico trial, of the 22 patients who had these CT scans, of the 55 patients who had the CT scans, of the 8 who were on warfarin at the time of CT, none of them had this leaflet motion problem. Of the patients who were not on warfarin, over 50% of them had the problem, and an even higher rate of those on dual antiplatelet therapy. So it suggests that dual antiplatelet therapy actually isn't enough to prevent this, if indeed this is thrombus. And while the numbers are really small and not statistically significant, and you can't prove causality, there's certainly a signal to suggest that there might be a higher stroke rate in those who have reduced leaflet mobility. When we look at the patients in the registry, very similar results. All of the patients who are on warfarin at the time of the CT scan, among them, none of them had this reduced leaflet motion, and almost 30% of those who are on dual antiplatelet therapy had this reduced leaflet motion. And again, there was a signal for slightly higher stroke rates. But again, numbers really small, doesn't really prove that's true and unrelated, but certainly is enough of a signal to cause concern. So what happens if you start warfarin on these patients? Well, we had 21 patients who had had a repeat CT scan after the initial one showed the reduced mobility. And of the 11 patients who were on warfarin, this reduced leaflet mobility resolved in all 11. Of the 10 who were not on warfarin, it only resolved in 1, meaning 9 of the 10 continued to have persistent reduced leaflet mobility among those who weren't started on warfarin. So what do we know so far? So we know that reduced leaflet mobility seems to happen at a much higher rate than we previously appreciated. It doesn't seem to be detectable by an increased gradient by transthoracic echo, and to me this is the most concerning thing, because this is how we follow these patients. We're not routinely subjecting them to transesophageal echoes or repeat CT scans. The rate seems to be greatly reduced in patients on warfarin. There's a thrombus-like mass seen on CT and TEE that correlates with the areas of reduced leaflet mobility. It seems to go away when we start warfarin treatment. Dual antiplatelet therapy does not seem to reduce the rate, and there seems to be a correlation with, or at least a signal for a higher rate of stroke or TIA. So the question is, do I think that TAVR and SAVR thrombosis is real? And my answer to that is yes, I think this is real. But whether it's a real problem or not, we don't know yet, because how to handle this and what to do with this is really not clear right now. With this publication in the New England Journal back in the fall, there was this accompanying editorial written in part by some of the folks at the FDA, and I think it was a very fair assessment. They basically said, look, this is something that's really caught our attention, and we think this is something that is serious, and something that really needs further clinical investigation. But what we also know is that the clinical outcomes data, what we really care about, death rates and stroke rates, are really, really good with TAVR, and they continue to improve, and the stroke rates are really low and continue to get better. And we should not be withholding this therapy at this time from patients who really need this, because we know this is really life-saving therapy for many patients, particularly those who don't have options for open surgery, but we really need to investigate this further. The other thing that they pointed out, and in my opinion, this is probably, at least in part, an explanation for this, is that this may represent a subclinical advanced imaging phenomenon. As Dr. Hurwitz showed us earlier today, CT technology has advanced very rapidly in the last few years, and I think we're just seeing things that we weren't seeing before. And what this means, I don't think anybody knows clinically yet, and certainly what to do with antithrombotic therapy is a real challenge, because we're talking about an older, frail population with lots of comorbidities, and all of a sudden saying we need to systemically anticoagulate all of them and put all of them on warfarin, I don't think is the right answer either, because many of these folks have bleeding complications or GI bleeding as a reason that qualified them in part for TAVR. So what we need are more trials, antithrombotic trials for TAVR, and thankfully there are some that are ongoing, some that are about to start, more that will start in the future. I want to share with you some of the data that Matt Sherwood shared with me, and he showed us earlier today, which is fantastic data, looking at what's going on in the commercial population in the U.S. today out of TVT. And so on the left are patients who have an indication for anticoagulation or systemically anticoagulation, or systemically anticoagulated. On the right are those who don't have oral anticoagulation. And you can see for those who are anticoagulated, about almost 3/4 of them are being treated with just aspirin or P2Y12, 16% on dual therapy, or this would be triple therapy, and 11% that are getting neither aspirin or P2Y12. Among those who don't need anticoagulation, 61% are on dual therapy, 14% are getting neither, and 25% are either getting aspirin or P2Y12 therapy. The point of this slide, and the point I wanted to make with this slide, is that what's happening commercially really is still all over the map. And we don't exactly know the answer quite yet, although as Matt shared with us earlier, there seems to be a trend towards improved survival in those who are anticoagulated. But again, there's a lot of selection bias on who we feel comfortable anticoagulating and those we think are too risky for anticoagulation. So there are 3 trials that I'm going to talk about here in concluding minutes that are trying to answer the question of the appropriate antithrombotic or antiplatelet strategy after TAVR. And these are the ART trial, the Galileo trial, and the Chloe trial. So the ART trial is a multinational randomized control trial that's being coordinated out of Quebec. It's studying aspirin versus aspirin and clopidogrel for the prevention of major ischemic events, which are defined as MI or ischemic stroke or death, without an increased bleeding following TAVR. The primary outcome is 3-month incidence of MI, stroke, TIA, or major bleeding. Secondary outcomes include cardiovascular death, minor bleeding, and cost effectiveness. But patients who need anticoagulation are being excluded from this trial. Major bleeding in the prior 3 months is an exclusion, prior intracranial hemorrhage, and drug-eluting stent within the past year are also exclusion criteria. So this will help us answer a question for a subset of patients, but many of our patients have AFib, have a need for oral anticoagulation, have had recent drug-eluting stents, but we expect that this study will be completed in the next few months. Galileo trial, in my mind, is really the most interesting of the 3 because it's looking at a novel anticoagulant, rivaroxaban, and looking at its role after TAVR. So this trial is looking at comparing a rivaroxaban-based strategy to an antiplatelet-based strategy to reduce the rate of death, the first thromboembolic event, without a rate of increased bleeding. And I think if this is positive in terms of supporting the use of novel anticoagulants, I think we will find a new role for the novel anticoagulants after TAVR. But it remains to be seen in the valve population. Yet, as most of you know, the novel anticoagulants have always performed very well. So the point of this is to study rivaroxaban plus aspirin versus aspirin plus clopidogrel. And we anxiously await the results of this trial. The primary outcomes being death, thromboembolic event, or major bleeding according to the BARC classification. But again, there are some major exclusions that will prohibit us from really being able to answer this question in a lot of the patients that we treat with TAVR. Those who have a need for oral anticoagulation, such as AFib, those who've bled in the past, those who need dual antiplatelet therapy, recent stroke, planned PCI. But for many of our patients that we treat, I think this Galileo trial will be very insightful and helpful to us in understanding what might be the right anticoagulation strategy after TAVR. And then finally, the Chloe trial is interesting because it's being in part built off of the TVT registry. So this is in part a pragmatic trial that's helping to use some of the infrastructure that already exists to collect this. This is studying clopidogrel versus no clopidogrel after TAVR, and patients, and it has much looser inclusion criteria. Patients who are on aspirin and or anticoagulation will be allowed in this trial. It's just basically randomizing clopidogrel versus no clopidogrel. It's a prospective registry-based clinical trial built off of the TVT registry platform. So hopefully this trial, which should be relatively easy to enroll in, should help provide some answers. So in summary, what I think we've learned so far is that, at least in my mind, this bioprosthetic valve thrombosis is real. I think that on imaging it looks like thrombus. It seems to correlate with reduced leaflet mobility. It doesn't seem to exist at a very high rate at all in those who are systemically anticoagulated, and it seems to go away after anticoagulation. But I think part of this may be that it is a new finding of an old problem just due to advanced imaging. We now have, and as those of you who have seen the Terra Recon display and have participated in Lynn's breakout session, we are able to obtain amazing images of the heart and of these heart valves, and I think we're just seeing things that we haven't seen before, and we know that routine chest wall echo just doesn't pick this up. It's also not unique to TAVR. It's found in surgical valves, although it appears to happen at a slightly less rate in the surgical valves than the TAVR valves. It's undetected by standard TEE, but whether we should be subjecting all of our patients to transesophageal echoes or the radiation of a repeat CT scan, we don't know yet. But one thing that the FDA has now mandated is that all TAVR trials in this country moving forward now are required to have patients enrolled in that study come back for repeat CT scanning, again to assess this mobility issue on these leaflets. So we'll continue to gather more data as time goes on, and I think the FDA is taking a wise approach to this and saying we're not going to slow down or prohibit commercial use of these valves. We need to collect more data. We have ongoing trials in the US. Let's use that opportunity to rescan these folks and bring them back. So the low-risk trials that are launching with both Medtronic and Edwards have this leaflet mobility study component to them by CT after valve implantation. The other thing we know is that it seems to improve with anticoagulation. It may increase the risk of stroke or TA. There seems to be a signal there, but we don't have enough data yet to say that for sure. And ultimately, as I've mentioned, we really just need further investigation. So with that, I'll conclude and happy to take some questions. Thanks.